Okay, first of all, thank you very much for the invitation and for having me. I do want to just start off though with a minute's silence, just as a mark of respect for what happened, the atrocity that happened in Orlando at the weekend. I'm going to be talking about an aspect of LGBT history, but it's important that we remember that LGBT people today are still subjected to oppression and persecution. So just a minute's silence just to remember what happened, those people and those families. Okay, thank you very much for that. Okay, right, so as was pointed out, what I'm going to be talking about today is my new book. So Curing Queers, Mental Nurses and Their Patients, 1935 to 1974. So quick rationale for those dates. 1935 was the year that the first official report on the use of aversion therapy being used to cure homosexuality was published in a medical journal. And 1974 was the year that the American Psychiatric Association removed homosexuality as a classification of mental disorder. Now, it's important to point out that the World Health Organization didn't actually remove homosexuality as a classification of mental disorder until 1990. However, the treatments did appear to peter out in the mid to late 1970s, mainly because of the reason of one of the reasons was the American psychiatric decision that I've just described, but also with the advent of gay liberation. Gay men and women were starting to unite during this period and actively refute that sickness label that had been attributed to them. And what this study does was essentially I interviewed nurses who administered treatments to cure homosexual and transvestites, people who were considered to suffer from transvestitism, and the nurses who administered those treatments and patients who received it. So, as I said, it was mainly based on oral history interviews with those nurses and those patients, but that was also supplemented by archival searches. And there's archives at the Hall Carpenter Archives, which is the London School of Economics, the Royal College of Nursing Archives, which is in Edinburgh, the Lesbian and Gay News Media Archives, which is known as LAGNA, which is at the Bishopsgate Institute in London, the Wellcome Trust Library and the National Archives. So as well as the oral histories, I went to the archives and kind of found relevant primary sources that supported the work that I was doing. So recruitment to this study was a particular challenge, and one of the reasons for that is that it's only been estimated that about 1,000 people in the UK ever received aversion therapy for homosexuality. So finding people who were willing to speak to me and still alive was particularly challenging. However, I did manage to find a sample. And I did that by putting adverts in gay establishments and within the gay media. I did talks at local and national older LGBT organisations, did an interview on a local radio station, and to get the nursing, that was to get the former patients, and to get the nurses, I put an article in the nursing press, and then I also got further nurses through snowball sampling. Snowball sampling, just to make everyone aware, is when the participant puts you in contact with another person who has a similar story to tell. So it's important to point out that all the names that I'm going to be using today are pseudonyms. And you're going to be hearing the voices of the patients and the nurses. Now, they're not actually their voices, they're their words, but I've used actors to recreate their voices. So hopefully the technology will work and you'll be able to hear that, but it just adds, I think it adds an element of authenticity to the presentation. So it's definitely their words, just not their voice. So the participants, former patients. I managed to find 8 former patients who underwent these treatments. Now I'll tell you what the treatments were later on, but they were all male at the time they received the treatment. However, 2 later underwent gender reassignment surgery, and they're now living as trans women. And their ages ranged at the time of interview between 65 years and 97 years. 7 identified themselves as Caucasian and 1 as African Caribbean. 1 was originally from Jamaica and the rest were from the United Kingdom. So this study is in the United Kingdom, just to point that out. And of the 17, of the nurses, I managed to recruit 17. And there were 8 men and 9 women. And at the times of their interview, their ages ranged to 63 to 98 years. So the oldest nurse that I interviewed was 98, and she trained in the 1930s, so quite a way back. 5 of them trained in the 1950s, and 8 in the 1960s. And they all worked in the National Health Service, so the NHS. And all identified themselves as having Caucasian ethnicity. 1 was originally from France, 3 were originally from the Republic of Ireland, and the rest were from the UK, Jersey and the Isle of Man. I just want to give a quick whistle-stop tour of the medicalisation of sexual behaviour. We haven't got much time, so I'm going to kind of whiz through it. But sodomy in the UK was initially outlawed as a capital crime in England in 1533 by the Buggery Act of Henry VIII. And in 1886, Krafft Ebing came along. He was a professor of psychiatry at the University of Vienna, and he published his seminal Psychopathia Sexualis. And this was the first clinical attempt to analyse and synthesise and formally classify most sexual perversions. And early attempts to cure homosexuality initially used hypnotherapy. And Krafft Ebing was a pioneer of this, and he began treating homosexuals using this approach. And he also reinforced these treatment by encouraging his clients, his patients, to visit the local brothel. So in the UK, Havelock Ellis and John Addington Symonds published their masterwork in 1897 entitled Sexual Inversion. And this was the first British attempt to synthesise biological, anthropological and psychological knowledge on the subject of sexuality. In 1905, Freud came along with his 3 essays on sexuality, and they were originally published in German. And following translation, his work, the psychoanalytical approach, began to have a pioneering influence in understanding sexual deviation in Britain. And this psychoanalytical approach kind of was reigning supreme in the treatment of homosexuality until the mid-1930s, when Louis Max published his paper on aversion therapy being used to cure homosexuality. And this is where my study starts. And what he required a homosexual patient to do was to fantasise about an attractive same-sex sexual stimulus in conjunction with receiving strong electric shocks. Now, I'll go on to tell you what the treatments were later on, but this is where the study starts. So why did people put themselves forward for these treatments? Well, there were a number of reasons or motivations why the patients put themselves forward for the treatments. And a lot of the patients sought treatment of their own accord. The majority actually put themselves forward for this treatment because they were so disturbed by who they were, by their sexuality, and they were willing to do anything to try and change that. Another reason was they were diverted through the court, so they were given entrapment by undercover police officers, was very common in the UK during the 1950s and 60s. And patients with people, these people who were entrapped were then given an option of going to prison because it was illegal. Homosexuality was illegal in England and Wales until 1967. So they were given an option of going to prison or going to hospital to be cured. And many chose the hospital because if you're given that choice, what do you want, hospital or prison, it's not a difficult choice. And also due to unsupportive family, police, social and media attitudes. So these were all kind of motivations and reasons why these men put themselves or came into contact with psychiatric services. Now these media articles here give us some idea of the messages that homosexual men were receiving about themselves. So on the left-hand side we can see an article called Twilight, meaning homosexual. I don't know where they got that from. Twilight men, now they can be cured. And this is discussing how homosexual men can be cured. Now what I think is really, really interesting and slightly disturbing, quite macabre about this, is that they've pictured a Twilight man looking furtively at children playing in a park. And what I argue is that this kind of reinforced that familiar stereotype that homosexuals had predatory, paedophilic tendencies. And we have, on the other side, we have an article in The Observer called How a Doctor Cured a Homosexual. And this is the medical correspondent from The Observer reporting on an article that was published in the British Medical Journal only a few weeks earlier about a case study of how a doctor had given aversion therapy to a patient who is now cured. So now we come on to one of our first participants. Now Uhtred received chemical aversion therapy in the 1950s, and his story really, when he's talking about the newspaper article, what he's actually referring to is the article that we've just seen, the Observer article. So hopefully this will work.
I was a veterinary student, and I remember, well, I'm sure you can imagine, it was a very masculine environment, spending lots of times on farms. And I knew I was queer, as they called it then, but I was desperate to be normal like all the other lads in my course. I remember we were in the common room one Sunday morning, slightly hungover from the night before, and the lads were taking the piss out of each other. They'd read this article in The Observer about a homosexual being cured. They were basically saying, "Look, James," this is a fellow student, "there is hope, you can be cured." I remember joining in with the bravado to fit in. However, once they'd all gone, I took the paper to my room and I read it properly, and I remember feeling a sense of hope, as most of the other things I read about men like me were pejorative, to say the least. Anyway, I made an appointment to see my GP the next day to ask for this treatment.
So Uhtred read the article and he went to his GP, who then referred him to a psychiatrist in the National Health Service who was specialising in administering this treatment. Albert Holiday is slightly different. Albert had aversion therapy in the 1960s, and he was already married with children, and his story kind of, he says, he talks about the turmoil he found himself in.
This was terrifying, really, because I was thrown into confusion, and it made me very poorly, because I had 3 children, little ones, and a wife, and we all loved each other. We had been building our lives, you know. I was very fond of my wife as well, and everything was going okay. And then all this began to happen, and it threw me into awful confusion, and it made me very, very poorly. And so I thought I had to go to the doctor. So I did.
So again, Albert went to his GP and was referred again for the treatment. Can everybody hear these? Yeah. Okay. Now Percival was the only participant of mine who came into contact with psychiatric services through the courts. And Percival recounted quite a very touching story of he was a butcher. He inherited his family's butcher shop in East London, and he was walking home one winter's evening, and he decided to visit a public toilet on his way home from work, and in his words, he went there looking for love. When he was in the public toilet, a very, again in his words, good-looking man approached him and made a sexual advance towards him. When Percival responded to that advance, he was arrested. The young man was an undercover police officer, and he was given the option of prison or hospital.
Well, when I was given the option, prison or hospital, well, I just thought that if I go to prison, if the other inmates found out what I was in there for, well, I just thought they'd kill me. I mean, I was fairly accepting of my sexuality, but in society, and particularly within a prison, it was viewed in the same light as a paedophile. No, I'm not going to prison. That's all I could think. So I just said, yeah, I'll go to hospital for the aversion therapy. I knew it was not going to make me straight. I didn't want to do it, but it seemed like a better option than prison.
So hardly a choice for Percival there. So, what were the treatments? Well, there were two types of aversion therapy. There was what most people will probably know about is electrical aversion therapy, and we can see two pictures of electrical aversion therapy here, so bottom left and right. And what this involved, it involved a man sitting on a wooden chair, and his feet would be attached to electrodes, as we can see here, or it's either his feet or his hands, and we can see that in the other picture here. And what would happen, the man would sit on this wooden chair and be in front of a projector screen. And on that projector screen would be shown images of naked men. And every time he saw an image of a naked man, he would be given an electric shock. Now sometimes, and it was usually the nurse who was pressing the button to give them the electric shock. Sometimes those shocks were given automatically because the man's penis was measured, it was attached to a penis transducer. So is there any change at all in penile measurement, he was given an electric shock. Then he would be shown pictures of females, as we can see here, and not be given an electric shock. So it was essentially based on Pavlovian classical conditioning. You would associate the pain with the men and no pain with the female. So that was electrical aversion therapy. There was also chemical aversion therapy, which in my opinion was a lot more barbaric and a lot more invasive. And it would involve the man being nursed and being admitted into a psychiatric wing, a side room of a psychiatric wing, as we can see here. And in that room there would be nothing except a bed. There would be no toilet, no basin, no sink. And they weren't allowed out of that room for up to 3 days. So 72 hours they were usually in that room. And every 2 hours it was the nurse's role to come in and give them an injection of apomorphine, which, as some of you may know, is a very, very powerful emetic. It made them violently sick. They weren't given any food or drink during this 72 hours. And so you can imagine after a few hours, let alone 72, you were lying in your own elimination. And that was the whole point of it, because pasted all around this room were pictures of men, naked men. So you was to associate this vomiting, lying in your own elimination for up to 3 days with these pictures of the men in that room. After 3 days, the patient was allowed out of the room. The nurses usually cleaned the room, changed the pictures to females, and they were given an injection of testosterone. When that started to work, which could take a couple of hours, they were encouraged to go back into their room and masturbate over the pictures of the females. So you can understand why I consider that, they were both, through a contemporary lens, barbaric treatments, but I think particularly the chemical aversion therapy. There was also estrogen treatment, which was colloquially known as chemical castration, and probably the most infamous person who received this was Alan Turing, and he was given the option of prison or hospital again, and he chose to receive the treatment. After the treatment, patients usually went through social skills training, and one of the nurses will tell you about that later on, so I don't want to labour too much point on that at the minute. But what I do want to point out is that none of the treatments that I've just described had any general protocol or ethical guidelines. The treatment of choice was very experimental and usually based on the unilateral decision of the consultant psychiatrist, underpinned by no evidence at all. So these are some of the reflections on the treatments. Now they are quite, they are quite powerful. So just to make you aware of that. But Greta Gold received treatment for transvestitism in the 1960s, and she had electrical aversion therapy. She's now undergone gender reassignment surgery and is now living happily as a trans woman. So this is her story.
I remember sitting in the room on a wooden chair, dressed, wearing women's clothes. But I had to be barefoot as my feet had to touch the metal electrical grid. My penis was also wired up to something to measure if I got an erection. I felt totally violated. I remember the excruciating pain of the initial shock. Nothing could have prepared me for it. Tears began running down my face, and the nurse said, "What are you crying for? We've only just started." I was speechless.
So Herbert Bliss remembers he's reflecting on the chemical aversion therapy that he had.
I can still taste the vile, stale sick in my mouth, and all I wanted to do was wash my mouth out with fresh water, but I wasn't even allowed to do that. I remember trying to sneak out of my prison cell one night to get some water, but the nurses caught me and literally threw me back in. It was 72 hours before I got out. 3 days I was locked in there. I went to the toilet at the bed. I had no basin, no toilet facilities, nothing. I had to lie in my own vomit and excrement. I was in a terrible state.
Okay. So they obviously reflected on that and remembered that quite macabrely. So nurses, people like us, administered this treatment. And, this is one of the things I was very aware of as a historian, to not judge these nurses, and we had a discussion about this in the seminar earlier, about, we can look back on this through a contemporary lens, and, and rightly so, kind of, oh my God, how could you possibly have done that? It's barbaric, it's torture. However, there were a lot of cultural, political aspects that were at play at the time that influenced nurses' decision-making around that. And through the process of my analysis, the nurses who I interviewed almost fell into two camps. And insofar as we can categorise, they either fell into the subordinate or the subversive nurses. And the subordinate were kind of, they were kind of subdivided into these three categories as well. So there were some of the subordinate nurses were unquestioning and inquiring. Nursing during that period was a very subordinate profession. A good nurse then was one who did as they were told, they kept their head down and they didn't ask questions. So some of these nurses fell into that camp. There were some that sensed that there was something wrong in what they were doing. However, they kind of limited their morality around that and limited their culpability by kind of almost diffusing the responsibility of it. And while it's important to point out the different context, I do draw some parallels with the nurses in Nazi Germany and the nurses in this study. Like I said, there's very different contexts. But what both nurses did was that they almost shared responsibilities. So they would say, well, I didn't give the injection, John gave the injection, I just took his observations. So it was almost like, well, if they're doing it, then it's okay, and we've both this shared responsibility for it. And then there were some nurses who genuinely believed that they were being beneficent. They genuinely thought that they were helping these people. Because, like I said, the majority of the patients actually put themselves forward for the treatment. And at the time, the doctors, the medical press, the medical journal, the medical literature. This is what was the revolutionary treatment for these people. So you have patients who are desperate to be treated. You have medicine saying that this is this is the only treatment and the best treatment we have available. These nurses genuinely believed that they were acting in their best interests. And this was particularly, I haven't got enough time to go into this in detail now, but you'll have to read the book. But it was particularly the case because 5 of the nurses who I interviewed were also gay themselves, and they administered this treatment, which I thought was really, really interesting, because I thought, well, as a gay man myself, would I have done that? I don't know, would I? It's who can say? But what these nurses did, the gay nurse, the nurses who identified themselves as gay, was that they said that they identified themselves as very different to these patients. They were at ease with their sexuality, however the patients weren't. And as a result of that, they actually thought that they were doing good by trying to help them and cure them. So they were the subordinate nurses. Now the subversive nurses are my favourite. I shouldn't have favourites, but they were the most interesting nurses to interview, and had some great anecdotes. And there's a whole chapter in the book called Subversive Nurses. And what these nurses did was they got out of administering these treatments in really quite clever ways. Because they did question the treatments. They did kind of go, wait a minute, this is, I don't want to do this. For whatever reason, whether it was their own ethics or their own moral compass, these nurses didn't want to do it. But they knew that if they were oppositional and they were, defiant and said steadfastly, I'm not going to do it, that could lead to them being dismissed, because opposition by nurses during that period in mental hospitals was a direct route out. If you started to say no to a consultant or to a senior nurse, you were seen as a troublemaker, and constructive dismissal was very common during that period. So a lot of nurses had to toe the line. But these nurses kind of got out of it, and we'll hear a subversive nurse shortly. These nurses got out of it in quite clever ways, which really interested me. So this is, Gilbert is a subversive nurse, and he was one of those nurses who kind of fell into that uninquiring and questioning.
Our job, to all intents and purposes, was to follow the doctor's orders. I mean, you have to understand the power of the doctors, nursing officers and matron in those days. You stood up to attention with your thumbs down your creases. For example, when the doctor came on the ward. Likewise, when the matron or nursing officer came on your ward, they would check it all the beds were in line, all the wheels pointing exactly the same direction. The beds, well, they had to be turned down from there to there. Exactly. They even measured to make sure it was. No one ever told me why we had to do that. I don't suppose anyone ever thought to ask. It was the same with aversion therapy. I didn't ask why, I just did it. It was the doctor who needed to know the whys, what ifs and maybes in my day.
There was very much a culture of do as you're told, don't ask questions. I think it's also important to point out that in another kind of element of an interpretation for why these nurses perhaps did this was that they were also, psychiatry at that time was very experimental. And, particularly during the 1930s, we had a surge into the proliferation of somatic treatments coming to the fore. And there's some examples of these here. So if we kind of look for the top left here, what we can see here is the patient being given cardiazol treatment. And this was essentially a precursor to ECT. And it came about under the mistaken belief that people with epilepsy don't suffer from schizophrenia. So if we make people fit, they're not going to develop schizophrenia, or it's going to cure them of their schizophrenia. And there's some very, in my book, there's some really quite powerful anecdotes of patients remembering having this treatment. We can see here on the right hand side, this is ECT, electroconvulsive treatment being given, ECT. Got to point out, ECT is still used today. But it's used under much tighter, certainly in the UK, and I'm sure it's the same here, under much tighter restrictions given for people with severe treatment-resistant depression, and it's given with a muscle relaxant and under general anaesthetic. Back then, you had no general anaesthetic and you had no muscle relaxant, you were given straight ECT or modified ECT. Bottom left, we can see insulin treatment being given, and this involved the patient being put into a deep insulin coma for up to days at a time, up to 3 days at a time. And what would happen is they would then be brought round, as we can see in this picture, by being given an NG tube would be passed, and a glucose solution would be passed through that tube to bring them out of the coma. And probably the most invasive of all was the leucotomy or lobotomy. And, you know, as I'm sure you know, this involved an ice pick that was put through the patient's top of their eye here, and then just hammered where you can see it, you know, just randomly, just really arbitrary, just tapped away. And it was trying to change the frontal temporal lobe, which we know affects people's regulates people's behaviour, etc. So there was minimal evidence, but if not no evidence base to these, and they were very, very experimental. And I guess what I argue is that the nurses who administer the aversion therapy, most of them also administered these treatments. So they were normalised and socialised to administering treatments that were invasive, painful to psychiatric patients. You know, there was a perception that psychiatry, you know, they need these somatic treatments are the way forward. So, you know, another strand of analysis, you know, the nurses were also administering this. When we look at what I've just described as aversion therapy compared to lobotomy, you know, it's kind of not as bad, really. Still, obviously, is bad, but when you compare it to that, they're both very invasive, and nurses were used to administering evasive treatments. Now, this is the subversive nurses now. So Elizabeth Granger was a really interesting nurse to interview. She was one of the first nurses in the UK to undergo a degree-based nurse education in the 1960s. We were slightly behind in the UK to you guys over in Canada, and it didn't become an essential requirement for all nurses to be educated within a university until the late 1980s, early 90s. Most nurses underwent an apprenticeship-style nurse training in hospitals. But Elizabeth was one of the first to undergo one of these revolutionary degrees in nursing in the 1960s. And I argue that this is, and she argues herself, reflects herself, that this essentially prompted her to question these treatments. So this is Elizabeth's story.
I suppose being a university nurse, I was more inured to questioning practice, and I also enjoyed reading. Now, I remember reading an article in the Nursing Times about aversion therapy. I was a general nurse at the time, but was due to start my conversion course in mental nursing shortly. I would have done that training first, but at the time I only did the degree in general nursing, and my parents wanted me to do the degree, so I did that first. Anyway, going back to the article, I recall it saying that if a nurse is asked to administer aversion therapy and they didn't really want to for ethical reasons, then they should say no. Now, I distinctly remember thinking that's what I would have done if I had to do it when I started my conversion course, as I thought it was barbaric, and I really had no faith in the treatment. The science it was based on was very weak, if not non-existent. However, it wasn't as easy as that. The article failed to make reference to the complex hierarchical organisation of nursing and the covert and underhand bullying tactics that were used in mental hospitals to manage and get rid of oppositional people. So it was not as simple as just saying no. Luckily, I only moved into the ward once the patient had finished the actual aversion therapy and he was undergoing social skills training. Now, this meant that the patient would have to go on a pretend date with a female nurse to practice this, ready for when they do it for real. Ridiculous. Now, they were not officially known as dates. This is just what we jokingly refer to them as. It was essentially about building the patient's confidence around females. We certainly weren't supposed to have any intimacy with each other or anything like that. Nevertheless, being a pretty young girl, I was considered the obvious choice. I went on several dates with the patient in the hospital grounds. I had a ball. He would do sarcastic impressions of the matron, and the doctor, and be very effeminate. I'd be in fits of laughter. He had told the doctor the treatment had worked and that he was now attracted to women, but he confided to me that he had lied. I knew it hadn't worked, and he was still gay before he'd even told me. I wasn't bothered. I thought people should be who they are and want to be. I went back to the ward and reported that the date had gone well and that the treatment appeared to have had a good effect, and there was no obvious homosexual behaviour.
So essentially what Elizabeth did there was she lied. She went back and lied. And what I kind of argue that, I don't know if anyone's heard of the concept of responsible subversion. There's a concept called responsible subversion in nursing that was first posited by Sally Hutchinson, and it's a fascinating paper. And it essentially is about nurses breaking rules for the sake of their patients. And what I argue is that the subversive nurses in my study were responsibly subversive. They broke the rules, but they thought about breaking the rules, and they thought that that was in the best interests of their patient. So I talk about it in the book, this concept of responsible subversion, and there's a reference to it to the Sally Hutchinson paper, but it's really interesting in paper, a study that she did in the early 90s. Now, completely coincidentally, I interviewed Percival a few weeks later, and you'll see how I was shocked once you hear his story.
Once they stopped the aversion therapy, because I lied and told them that it had worked, I had to do the most preposterous thing ever. I had to go on a date with one of the nurses. I mean, can you imagine how contrived this whole thing was? I thought it was going to be with the nurse who had been giving me the injections for the past few days. So I thought, great, I'm going on a date with Nurse Ratchet. You're meant to be reinforcing my heterosexuality, not turning me gay again. Anyway, as it happens, it was a young student nurse who had just started on the ward who took me on these dates. I will never forget her. She was fantastic. We had such a laugh together. I used to do impressions of the matron. We'd be rolling about laughing. I trusted her so much that I actually told her that I'd lied to the consultant and that I was still homosexual. Although from the way I behaved around her, which I've just described, it wouldn't have taken a genius to work that one out. Anyway, she mustn't have said anything as I was discharged a few weeks later.
So I was absolutely, ethical implications dictated that I couldn't say anything. I couldn't say, oh my God, I've just interviewed your nurse. But I think what it does do is that, because they recounted the same date, same hospital, it's clearly the same story. But I think what it does do is it reinforces Elizabeth's decision making and her responsible subversion and how such positive impact it did have on her patient. So, the aftermath of the treatments. So, summing up now, so the treatments appeared to peter out with the decriminalisation of homosexuality in England and Wales in 1967, the removal from the DSM in 1974, and probably moreover the influence of the gay liberation movement in the early 1970s. None of the patients who I interviewed reported any efficacy. They either remained homosexual or underwent gender reassignment surgery and are now living as trans women. But what they all did do was reflect on the treatment and report how it's still quite disturbing for them. And I think Barrington's summing up and reflections of the treatment, it really does hit home how, even though these treatments were done quite a while ago, they're still having an impact today.
Over it. I never have. I have never come to terms with it. A guilt. Guilt. You can live with it, but how can you forget it? I desperately wanted the treatments to work, but they didn't. I can still have terrible flashbacks of my time in hospital and the barbaric treatments I received.
So Barrington actually put himself forward for electrical aversion therapy 3 times a week for over a year. Desperate for it to work, but it didn't. Okay, so what? So what can we draw from this study? So the testimonies show that courts and unsympathetic family, police and social attitudes essentially prompted people to seek these treatments. And I think what the study does is it exposes the equivocal way in which patients and nurses read and listened to influential cultural outputs at the time and acted in accordance with these. There was a limited evidence base and no general protocols or ethical guidelines for the treatment, and the treatments varied massively depending on where you were and what the consultant decided to give. And the efficacy of these treatments were based on self-reported outcomes by the patients, which led the nurses and patients to be able to subvert the treatment process, as we've seen from the testimonies earlier. The study also offers some intriguing insights into the hidden gay lives of nurses and into the hidden gay lives of some of the nurses, and the inevitable tension between their own identities and desires and the treatments they administer to others. So none of this, like I said before, none of the treatments reported any efficacy, and they had lasting negative impacts. And I guess defining homosexuality and transvestitism as mental illness and implementing what could be argued to be ineffective and brutal treatments to eradicate them appears to have had a lasting negative impact on the patients who received them. So I guess the so what for today, it's envisaged that this study may act as a reminder for nurses to ensure that their interventions have a sound evidence base, and that they constantly reflect on their morals and values and the influence that science, societal norms and contexts can have on changing views of what is regarded as acceptable practice. We can learn much from studying aspects of our own profession's past, in which our actions, even if countenanced by the context in which they were suited, did not serve patients and society well. Thank you very much.
Thank you, Tom. And there is some time for questions. And I think we take the 10 minutes up until 1. We break, and if there's some more questions, we can always take a few more minutes, but people will have to leave, and then so open it up for questions.
Tommy, Sally Thorne, loved it. It was wonderful. Send the papers to Nursing Inquiry. Excuse me. I'm not surprised that you didn't find any cisgender women in the study, but do you have any sense of whether they would have been treated differently by a dominantly female nursing population? Had they been in the study? Was there any of the data from the nurses that would have told you that way?
So I've got to repeat the question, I think, for the tape. So were any cisgendered?
Were women, lesbian women? I know they were disproportionately men that were given this treatment, but some women would have been. And would their experience with predominantly female nurses have been any different?
Okay, yes, you got that. Okay, yeah, it's a good question. So I originally did open the study out to women as well, but I didn't have any research, any participants. And one of the reasons for that, I argue, is that lesbianism, certainly in the UK, was never illegal. So that route of prison or hospital was never an option for women. That's not to say that these treatments weren't administered to women. They were. It was in a much smaller, there's a much smaller proportion of women who had them. Out of all the papers that I found, there was only one published study that discussed the treatment being used on a woman. So it was, that gives a reflection of the extent that they were treated for women. How would they have been treated differently with a predominantly, female nurses? I'm not sure. Possibly, but because I didn't interview anybody who had that experience, it would be difficult for me to say. But I think the important point is that the treatments were given to women as well, and they were offered to women, but a much smaller proportion received them. Okay? Yeah?
Thanks very much, I have a question about, so you had that situation with Nurse Elizabeth, and the story was corroborated by the other gentleman that you interviewed. And I'm just wondering, for some of the other subversive nurses, if you're interviewing them in the sort of present day, where they might have some post hoc rationale for why they did what they did, how did you corroborate those? Did you go back and look through the health records and see, did they sign off on things, or?
Yeah, so that's a really good question. Unfortunately, their records weren't available, and they'd been destroyed. So I couldn't go back and do that and look at those. And I guess in oral history, it's slightly challenging because we have to kind of, if that's the way they remember it and that's the story they want to tell us, then we kind of have to work with that. So one of the other subversive nurses, actually called Una Drinkwater, what she recounted was that she, instead of giving the injections, she went in every 2 hours and squirted the apomorphine on the floor and told the patient to pretend to be sick, because there was enough vomit around the room anyway for that for that not to be questioned. So I kind of, had to believe what she said, and that, but there was no other way of really corroborating that because the patient didn't come forward. However, what she did say was that the patient sent her a thank you card once he'd been discharged. And she brought a thank you card that looked pretty dated to the interview with me. And it was quite touching to actually see that, because she'd clearly kept it all of those years. And, I thought that was enough for me to believe what she was telling me. Yeah.
I have a couple of questions. One was about whether the experience of the Afro-Caribbean man was, are there intersectional dimensions to the way in which he was treated that you might be able to comment on? And then the second question that I have that I'm curious about is that you talked about the use of naked images of men and women as part of this therapy. Were those photographs taken specifically for that purpose, and who were the people who were being photographed? Do you have any sense of that?
That's okay. So the patient who was African Caribbean didn't highlight that he was treated any differently. He didn't. Nothing came out of that, and he was one of the patients that put himself forward for the treatment. The African Caribbean one was Barrington, the guy who was the one desperate to be treated, the one who put himself for the treatment for over a year. And I guess what he did say was that his family were very, very much totally unaccepting of him. So I guess that was something that was at play with him, and whether that influenced his decision to put himself forward for this extended period of time, possibly. The pictures, completely arbitrary, really. What the nurses recounted was that it was quite common for the consultant to kind of come with a projector under one screen and a lump of slides under the other, and just set this up in a broom cupboard almost at the end of the corridor. So there was not really much choice and selection. It wasn't a kind of systematic thing of finding good-looking men who would pose and good-looking women who would pose. It was kind of whatever they could kind of find, really. And I think that it kind of highlights the kind of lax nature of them. It was, and how, you know, it was just, well, the nurses just reflected on it as like it was just almost farcical in some cases, because, you know, the doctor really didn't really know what they were doing because they weren't doing it every day. It was just, you know, and it was kind of just setting this thing up, and sometimes it wouldn't work, and it was just, you know, because it wasn't something they were doing all the time. So yeah, it was, although there is a colleague who's looking into this specifically, and he's trying to find some of those images, but having no luck, because he's trying to make a film on it, so he wants to find some of the actual images, but he's really struggling with that. And when we spoke about this, he says one of the reasons for that is because it was just so random. It was anything they could find. Yeah.
And the photographs that you had of that, those were taken by.
Yeah. So those photos, the one with the chair, the wooden chair, that was an image from the Nursing Times. So the article that Elizabeth was saying that she was remembering about aversion therapy being discussed in the Nursing Times, that was one of the images from that particular article. The other one, which is...
Did that depict an actual clinical moment, or was that a
It doesn't say, and there was no way of me finding out. It doesn't say, and I did try and find out and get through to ask the publisher, but they didn't know about it. The other one, and that is the image that I've used on the cover of my book, that is actually an image that was from the Times newspaper in 1972. And what this paper is doing, because what I do throughout the book is show how the media initially were promoting the treatment, and then there was a shift in the 1970s owing to the gay liberation movement as well, and they were starting to critique these treatments. And it was a newspaper article in the Times that was I can't remember the exact the title of it, but it was quite, you know, pejorative, kind of, you know, psychiatrists fry the brains of gay people, something like that, and it was very, very critical of these treatments, and that was just an image that they had taken from an actual hospital. So that is an original image that they've used, but that's the only one that I've been able to find. Yeah.
You had a question.
Yeah, I was just wondering if you got to, in all your research, if you got to speak to any of the doctors that were prescribing this treatment.
I didn't, and that was a deliberate decision not to. There's a paper that's already been done and some research that's already been done about 10 years before my study that did just that. It interviewed doctors who administered this treatment. I wanted to look at the nurses, so obviously I did bring in their research and you know, weave that in, you know, to get the doctor's voice on things, but it was a deliberate decision not to. I wanted to focus on the nurses because nobody had done that, and being a nurse myself, I wanted to really kind of look at, you know, what it was about them, why they were doing this. Yeah. Oh, thank you. Thank you very much. Thank you.